Okay, so if you just sit towards the edge of the seat for me, put your feet together, knees together as best you can. All right, so I'm going to come up right underneath the PSI this, and first things first, I'm going to figure out how they sit. And it seems like this right one, it's a little higher and slightly wider than the left one. Okay, so if you keep your feet together and then fan both knees out as wide as you can comfortably and then back in. Good. Let's do that again. We'll go to the middle of the joint. Good. One more time at the bottom of the joint for me. Wonderful. Now just the right leg, sir. Top of the joint. You gotta right knee out and then back in. Let's do that one more time for me. Great. Now the left, please. Aha. And left one more time. Old trusty right. Okay, you can put your feet back to normal and scooch back if you like. So when he does both knees, I expect to feel the tailbone or the sacrum nutate or roll forward, and it does. And when he does just the right knee open and will close, I only expect to feel motion in the top and the middle and the bottom of the SI joint on the right versus the left. When he does the left, however, I can feel the right side kind of pull with me. So it tells me that we have a fixation on the right hand side. So now I know normal is left hand and abnormal is right hand. And so now I can get into some rotation and lateral flexion to figure out on the fixated side how stuck is it, what direction it is. But in order to do that, I like to get a really good idea of how the patient moves on the normal side, because every patient is a little bit different when it comes to normality. If you just cross your arms for me in front, sir. Thank you, thank you. And I'm going to just rotate you to the left and then the right at the top of the joint. I'm going to do that again at the middle. And then at the end. Wonderful. We're going to come back up. We're going to laterally flex you to the left. And I should expect to feel that pelvis raise. We're going to laterally flex you to the right. It should lower. And then we're going to do that one more time, sir. And I expect the tailbone or sacrum to close and open. And it does all those fun things. Now, we'll see about this. We're going to start with rotation. So although I can rotate the patient, I'm rotating the patient above the SI joint and probably, seemingly, into the mid-lumbars there. There's no real rotation at the top of the joint, nor the middle or bottom. I'm going to laterally flex the patient over to the right. It does not raise. I'll laterally flex the patient to the left, but it does lower. And then we're going to come back over, and it sure closes. And it stays that way, it does not open. So, real quick, what I'm building is we have a right-sided problem, and if it's stuck down, it's a PI. And then if it's stuck in, it's an IN. So real quickly, we build a PI-IN on the right-hand side, and then we can verify it with the X-ray. And he does have, and of course these are a few months old, but he does have an IN on the right-hand side with almost nothing on the up or down aspect of it. Okay, now we're going to do a little bit of scoping. Scope all the way down a couple of times first, looking for deflections. And I do start a little high, probably about T1, T2. And we're going to go all the way down, seeing what we see. Deflections. We're going to do that a couple of times to make sure we're not just seeing a heat swing, surface temperature type of stuff. If it is a true subluxation, that deflection will be there whether it's cold or hot. Make sure you don't go off track. Yeah. All right, I got two that are bumping out at me. Right there. Forward, please. Towards the heart this morning. And to the base of the neck. One last time. Yes, sir. Okay. Alrighty, righty. Now we're gonna, the 5 steps you guys already know about, but visualization goes through all of it. Although it's a numbered step, it happens throughout the whole thing. So when you're looking at the patient, there's a couple of things to note. Obviously, the right high shoulder, left low shoulder. So we're going to look down here, and you can kind of see a little slight deviation or bend right there. A very good way or visualization is if you bring the patient over just slightly, we should see a natural arc. And that straightens it right out there. And bring the patient over. Just going to do it one more time on the left. Thank you, sir. Kind of comes here, and then it straightens out, and we get that little bit of a curve right here with a sharp bend here. You see that? Okay. Over this way again. All right. So now we've got a natural arc. It kind of straightens that right out, doesn't it? So we definitely think that this is maybe throwing something off. It's also altering the transition zone. You can see the thickness of the paraspinal muscle here versus over here. And then we're going to feel for edema by running our fingers down both paraspinal muscles. And although this one is more pronounced, it's really pronounced right there. It really loosens up right here. And then just dips right into a little bit of fluid, and it's right over there. Okay, I'm going to hunch you forward just a little bit, sir, and I'm going to bring you back. So when you hunch the person or patient forward in the lumbars, you can open and close the joints, feeling for posteriority. That's not moving very well. And then if you hunch them forward again, so if the patient's just in a normal position and I bring them over to the left, I expect the opposite travel of the lumbar. But if you hunch them forward and then bring them over, it straightens that out. It's the same as up in the thoracics. And if it swings more towards, so for instance, I'm not feeling a lot of posteriority right here, and this is probably a little tender on me, isn't it? Yeah. And so if I bring the patient over, hunch him forward a little, and swing the patient over this way, that subluxation should go more into the side of the subluxation. So I'm assessing the spinous process below and the spinous process on it, and I'm feeling for that travel, and it really travels to the right way more than it travels to the left. So we're right about L4, and we're thinking it's moving like it's a PR for sure, and we do have a little bit of lateral flexion restriction more on the right than we do that, so a PRS perhaps. So PIIN, PRS, and this may be a compensation because of that, but we can recheck it. And then I always palpate up into the joints because especially in the imbrication area, it's very easy to slide over them when you're counting. So, you know, that little mark here, I start going under a couple of joints and I'm feeling for hardness of spinous process. And I'm going above the joints as well. And when I feel that softness, because that's where the inflammation will kind of bind up, how does that feel there compared to that one?